Hello, everyone. Good morning or good afternoon, wherever you're calling in from. I'm Grace Rubenstein with HealthBegins, and thank you so much for joining us at this webinar on designing and financing sustainable community health investments. I want to let you know just before we get started that we will be recording this webinar, and we will send out a link to you of that recording after the webinar is completed. All of your participant lines will be on mute during the webinar, but we're really interested in hearing any questions that you might have. So the way to send those questions to us is if you look at the pane on the right-hand side of your screen, you should see a panel there for questions. You can just type your questions in right there. We'll be monitoring the questions pane there throughout the webinar, and we'll reserve time at the end for Q&A and try to get to as many of those as we can. This presentation should last 1 hour. And we've got some great speakers and content lined up to share with you. With that, I'm going to hand it over to HealthBegins founder and president, Dr. Rishi Manchanda, to get it going. Rishi.
Thank you so much, Grace, and thank you to all of you for joining us today. Happy Tuesday, June 26th. We are really privileged to be joined today by Jason Helverson and Bill Panakiewicz. You're going to hear from both of them in a moment here, but I just wanted to welcome all of you to this webinar, which is the second in a series of webinars focusing on how to improve and sustain community health investments, in particular, how to help support the clinical and community partnerships, many of which are now emerging across the country to address social determinants of health in ways that also are aligned with the shift towards value-based payments. Today, we're going to focus on how to design and finance sustainable community health investments. Our hope today is that attendees, each of you, will be able to walk away from this webinar with the ability to identify barriers facing community-based organizations to participate in sustainable partnerships with health systems. We're also hoping that through the conversation today, you'll be able to describe the organizational and contract elements that can help promote these types of sustainable relationships between partners. And we're also hoping that to provide you with concrete ways to ensure that cost savings from the community health investments, especially these types of clinical community partnerships, can reach CBO partners who can in turn invest them in further upstream strategy and health promotion. This is a shorthand way of saying we want to look at ways to ensure that we avoid the wrong pocket phenomenon that many of you are familiar with. So with that in mind, with those learning objectives in place, again, welcome. We're going to give you a little glimpse again about HealthBegins for those who aren't familiar with us and are joining us for the first time. HealthBegins is an organization that is proud to work with a host of clients and partners across the country, including those at the bottom of the slide. We effectively improve care and the social determinants of health by working with our partners to make clinical and community partnerships more effective and efficient. We do this in a variety of different ways, helping to address a whole host of implementation challenges that many of you are probably familiar with. And again, work not just solo, but with a lot of our partners out there, including some of you who are online, to learn about ways that we can accelerate our efforts to move upstream. It's against that backdrop, that experience really, that today's presentation is relevant. And I thought, given the World Cup, given the topic, that we'd use this image to describe what we at HealthBegins are seeing, and perhaps many of what you guys experience joining us today. And what we're describing here is, of course, a lopsided playing field, an uneven playing field. This would be an unfair match for any World Cup participating team, unfair for at least those on the bottom of that slope, very, very fair, quote unquote, for those at the top. But if we use this image to instead consider clinical and community partnerships, partnerships between hospitals and large health systems and community partners, whether it's in the private nonprofit NGO space, or it's public health departments or other social sector partners, I think it's safe to say that many who encounter or are already embarked on these types of partnerships understand that there's a lopsidedness. Lopsidedness in terms of resources and infrastructure. The healthcare side of the house, the side of the field, I should say, has long historically received the lion's share of resources in the nation, going back several decades across different administrations and political affiliations. And that's led to relative underinvestment in the social sector, in CBOs, in public health, and other key elements of what we consider to be upstream solutions. And that is a really candid assessment of where we now look at these questions of how to design and finance community health investments. If we're going to optimize clinical and community partnerships, we have to do so against this backdrop, an uneven playing field. And so part of what today is going to be about is really to understand how to create a path to sustainability, or to level the playing field as much as possible while we build up these clinical and community partnerships as we move upstream, if you will, to address social determinants of health in particular through partnerships between the healthcare and social sector. Is there a way we can do so that not only meets the needs currently of each partner programmatically and financially, but also creates a path to sustainability? That's really the high-level question that we wanted to orient us all with today. And against that backdrop here, I'm proud to introduce Jason Helgerson. Excuse me, actually in a minute, I'll introduce Jason. Jason, I got ahead of myself, apologies. We actually wanted to engage each of you first with a poll, just to understand who you are, and then we'll have another poll question before we introduce Jason. So the first poll question here, we're about to launch. The question is, in which type of organization or department do you spend the majority of your time? Give us a sense of who you are. Are you a hospital, community benefits, or philanthropy related person, somebody in the philanthropy sector related to a health system? Are you a health plan or payer? Or do you work in a large CBO? Are you with a clinical care delivery side, or in a health system doing population health management or other? Let's give it another 10 seconds. And let's go ahead and close the poll. All right, let's see. It looks like the good representation of folks from CBOs and a whole bunch of other as well. And it seems like there's a small mix of folks from the clinical care delivery side, as well as a smattering of folks from the hospital community benefit department side. So the next poll question we'll go to is this one. So the next poll question is this: what are the top 2 reasons that your organization is in a clinical and community partnership to address social determinants? So A, are you in value-based payments and contracts? Is that one of the major reasons? In other words, we will be paid to do this work. Are you in are there regulatory requirements that are telling you to do this? So that's the option B, is we're being told to do this. Option C is that if the organizational leadership and your culture is actually guiding you to do this work. It's another shorthand way of saying that is, if not us, then who will do this? Are there other reasons, or are you just not in a clinical and community partnership at this time? Another few moments. Great, let's go ahead and close the poll and see where folks are at. Great, it seems like the top 2 reasons, as folks have identified on this call, are that it seems like number 1 reason is that your leadership and your organization is driving you to engage in a clinical and community partnership to address social determinants. It looks like a good number of you, you're not currently in a clinical community partnership. Perhaps this is a way to start to understand how to create that type of partnership. And there's some of you who are being driven by value-based payments. In other words, you're being paid to do this work as well. That's great. So Jason, hopefully that gives you a good backdrop of who's on the line today as we turn it over to you to walk us through your comments. Thanks so much, Jason.
Thanks, Rishi. It's a pleasure to be here today, and a pleasure to be able to address, as I saw the list of participants, those who signed up to participate, a wide array of individuals from organizations all across the healthcare continuum, including many CBO representatives, as that poll showed, which is wonderful, and also a wide array of organizations from all around the country. So glad to be here, participating from New York, but with our colleagues I know in Boston and Rishi and your team in LA. So I'm going to talk a little bit about the New York experience of trying to bring together the healthcare sector and the community-based organization, social sectors as part of our delivery system reform efforts, as well as the efforts and the opportunities that are created by the move to value-based payments. So if you want to move to the next slide. All right, so in terms of value-based payment, and I'm a big believer that at the end of the day that the future state of healthcare is going to be superior to the current state, in the sense that I believe that we are on a path that will not be changed, away from fee-for-service, away from a payment system in which there's very little link between outcomes and payments that are made to healthcare providers, to one in which more and more of the healthcare sector is accountable for results, accountable for the health of their communities, and that value-based payment is here to stay. I was struck, in fact, just this morning seeing about a fairly major announcement among self-insured businesses who are forming an alliance to support the move to value-based payment in their sector. So I think that it's fee-for-service is almost dead. It's not completely dead. You can look across the country and see that various states are in different states of their progress. But I do think that it is nearing its final end. And in fact, I think the move from fee-for-service to value-based payment is actually going to accelerate here. And I think it creates tremendous opportunities to go upstream, to move, to sort of rebalance the playing field, to use the visual that Rishi provided earlier, and to create a new opportunity for partnerships between different organizations across the health and social care systems that really aligns everyone to achieve the triple aim of better care and better patient experience, better population health, and better and lower costs, particularly lower costs on a per person basis. And some states, New York in particular, are really leading the way by aggressively moving their Medicaid programs into value-based arrangements. In New York, Medicaid is a $68 billion enterprise serving almost 7 million people. It's by far the largest purchaser of healthcare services in the state. And when you add together Medicaid and Medicare, which is also over the last multiple years has been moving to value-based arrangements and doesn't seem to be stopping even with the new administration in Washington, that's 50% of all payments to providers in the overall healthcare system moving to value-based arrangements here in very short order. New York is actually obligated in terms of one of its waivers to actually move 80% of all of its provider payments into value-based arrangements by 2020. Right now, about 40% of its payments are value-based. So it's about halfway towards its 2020 goal, but that means billions of dollars moving away from fee-for-service to value. And it really does create a new business case for partnerships between providers, CBOs, and other organizations to address the social determinants, because I think as individual organizations, healthcare providers start taking on risk for total cost of care and risk for improving patient outcomes, they realize they can't do it alone, and they need culturally and linguistically competent partners in the community who have long-standing relationships in those communities to help them address those social determinant health needs, because if they don't address those needs, they'll never get healthcare costs under control. But that said, it's hard work to build those relationships, and there's some lessons learned, and that's mostly what I'm going to talk about today. So next slide. So in terms of, go back a slide. Oh, I'm sorry, go ahead forward a slide, sorry. So just in terms of a few best practices for CBOs, then I'll talk about a few best practices on the healthcare side. So first, in terms of CBOs, it's really important for you to understand your community, and while that's important, it's not sufficient for you to be able to get into the contractual relationships, to get into the partnerships that really are necessary to be successful in a value-based payment world. It's really important for CBOs to flesh out their models, to understand who they served and where they add value, and really to build out their value proposition. And that it's not a grant world that you may be familiar with, whether that's grants administered by state and local governments, or the philanthropic environment in which you operate, where you're raising money to fund nice, good projects in your community. This really is a partnership based on value, based on your ability to demonstrate that you can support a group of healthcare providers who are held accountable for lowering total cost of care and for achieving very specific performance metrics. It's going to be important for CBOs to use the data that they have available to themselves to really hone their value proposition so that they can clearly articulate to the healthcare world what they can do to support those health systems in their community sort of achieve maximum success. And I think it's important to understand that what measures the health systems are being held accountable for. And I think and I'll talk a little bit about what health systems can do in that regard, but it's really, I think, important for CBOs to understand that it's not just about the things that maybe historically they've done or the areas where they've historically measured their performance, but they have to understand how does their activities, how do their efforts translate into helping those health systems or healthcare providers in their community achieve the goals that they're being held accountable for by their ultimate payers. Next slide. So in terms of best practices for healthcare providers, I believe at the end of the day, transparency is our friend here. If healthcare providers are going to be held, when I say healthcare provider, I could mean either a health system that's moving into a risk arrangement, say, as an ACO. It could be an IPA, an Independent Physician Association, which could be not just physicians, but a variety of different healthcare providers who come together to contract in a value-based type of fashion. Or it could be a health plan who already is capitated, already has an interest in lowering total cost of care, who could be looking for partners in the community to address social determinants of health needs. But I think these sort of best practices apply to either type of any of those types of organizations. But first and foremost is be transparent, show your measures so that the organizations know exactly what you're being held accountable for, so that they can begin to think about what they can do to help you move the needle in those key measures. Identify your challenges. If there are specific measures that you're falling behind on, that you need to work on, where you need help, identify those up front. Don't make it a guessing game for the community-based organizations, but definitely try to help those organizations identify what challenges that they can really hone their business case around, because I think that'll help you build the most fruitful relationships. And then lastly is help CBOs figure out how they can address very relevant measures. And I'll talk a little bit about some of the examples in New York, but I think this is the key thing, is that CBOs and healthcare providers don't speak the same language. And it's really important, I think, for both sides to begin to see the world through the other organization's eyes. And this is particularly important for healthcare providers. And I actually put more of the burden here on the healthcare sector because you have more resources. The playing field has been tipped in your favor. It really is important for you to invest in ways to be able to learn how to speak CBO. And one idea that I have is to think about how you can hire somebody from the CBO community in your area to help you translate and learn, and to be a good broker between your organization and the CBO community to build good, meaningful, lasting relationships. Because we think at the end of the day, those kind of relationships are really what's key. And then lastly, for healthcare providers is be flexible. This was a major lesson learned from our New York State Medicaid district experience. One of our early frustrations in our efforts in New York, we created 25 what we call performing provider systems. You can think of them as ACOs, covering the entire state. These were large organizations, hundreds, in some cases, thousands of organizations coming together in a community with a strong emphasis on engaging CBOs. But early efforts, particularly things like sort of RFPs out for very specific sets of services, did not work very well as a strategy. And that forced, basically, you put out an RFP and nobody responded. But a best practice emerged called an innovation fund. And almost most of the PPSs now have launched them, but they're a much more flexible contracting tool. What they do is they give you the ability to contract with organizations based on what that organization is capable of doing. It's not a grant program, but an outcomes-based program. And the way it works is that the PPS says, hey, these are the measures that we're going to be held accountable for. How can you, as an organization or group of organizations, help us achieve those? And that's why we think it's a very interesting model that could be replicated by almost any kind of healthcare organization out there, whether that's a plan or a provider group. Next slide. So just some lessons for both groups. First and foremost, VBP is about taking risk, and it's really important for both sides to understand that, and it's important for both sides to think about what that means relative to your performance and who holds the risk. Many CBOs are very wary of taking on risk, and value-based payment doesn't mean that a community-based organization living on a shoestring budget has to actually take on, say, particularly downside risk. That said, doesn't mean that they can't participate and shouldn't be a vital partner in value-based arrangements. They absolutely should and need to be in order for value-based payment arrangements to be successful. But what that also means is everyone needs to understand that whoever holds the downside risk, whoever's taking most of that risk, is also going to see most of the gain when the overall effort is successful. But you can go into these arrangements and basically share risk in innovative and unique ways. And I think that's really where a lot of this negotiation discussion between the parties has to come in. That said, there are particularly some of the larger CBOs are pretty well positioned to take some form of downside risk, meaning that they would be prepared. It could be risk just based on your contract fee, where you sign a contract to provide a set of services. But if you're unsuccessful, maybe there's a take back, maybe there's a prospective reduction in a rate of reimbursement. So there is some degree of downside risk, but it's much more limited. But I don't want to just scare all CBOs off, particularly larger CBOs off, from taking downside risk, because the benefit of downside risk is you get more of that upside value, you get more of the shared savings, and it gives you an even greater opportunity to level the playing field between the healthcare and the CBO sectors of this collective effort. Next slide. So in terms of this, it's really important for CBOs to view these contracts not as a grant, but really as an opportunity to provide measurable value. And I think that's the key thing here is, even if you aren't taking on downside risk, even if your shared savings model doesn't include a payment based on outcome, that there is going to be some sort of contractual element that's going to be linked to performance. It's not going to be about effort. It's not going to be about doing nice things. It's going to be, are your efforts, is the initiative, is the intervention that the CBO is launching measurably improving outcomes? Is it measurably assisting the group of healthcare providers in controlling total cost of care? If it's not likely to continue to receive funding through this initiative. And I think that's key for all sides to understand, but there are many ways within which to contract with CBOs, so that it could be a shared savings model, or it could be a contractual obligation or a contract element that would suggest that if you're unsuccessful, that contract would be terminated at some point. But it is important for everyone to understand this is not a grant. So how do you help CBOs address this challenge? And I think this is key, is that if the healthcare providers simply sit back and say, hey, CBOs, we're on the hook for these risk arrangements, if you're ready to come help us, then great. You apply to this program or reply to this RFP, this procurement document, and we'll evaluate you and wait for a response from us. That kind of sit back and wait kind of attitude is not going to work. You need to be much more proactive if you want to get good results. You need to communicate, engage, and train community-based organizations so that at the end of the day, the proposals you're receiving from them meet what it is that you as an organization need. This is not a competitive procurement process in a sort of government procurement sort of thing or type of structure where there's winners and losers. You really want this to be a win-win arrangement. Healthcare providers need CBOs to be well positioned to support their success. In a lot of cases, the only organizations in your community who are capable of providing those culturally, linguistically competent services, who know the people you need to reach in your community, only organizations positioned to do that are your community-based organizations. If you set them up to fail for failure through a procurement process that is not sensitive to the fact that they have significant challenges in that area, you're just not going to be successful. And when you're not successful in contract with CBOs, you're not going to be successful in a VBP arrangement. Some interesting best practices in New York, first and foremost, have been boot camps. Both the state did it, and now we're seeing these performing provider systems doing it, which is all day or multi-day sessions where you bring together those community-based organizations. and you really sit down with them and help them hammer out understanding and calculating what their value is, helping them hone their services to meet the needs of the community, really listening to them about what they're capable of or what they see the challenges are in the community, and really talking to them about what performance measures you're held accountable for. Let them help you design the right process for engaging them on a go-forward basis. Now, I would say one additional potential best practice is what we did in New York, which is, I think, pretty unique to the nation, which is that VBP contractors in the more advanced arrangements, that's where the health group of providers is taking on both upside and downside risk. Though in those situations, those VBP contractors, those providers must address at least one social determinant of health need of the members that they're serving, and this is key, must contract with at least one what was deemed a tier 1 CBO. And what's meant by tier 1 CBO is this is an organization that's a not-for-profit that doesn't bill Medicaid for the provision of services on a regular basis. So those are those classic CBOs that are out there in the world that are providing good care, running on those shoestring budgets that aren't your traditional healthcare providers, that they must contract with one of those organizations to address that social determinant of health need. So that requirement's now in place. The idea is to ensure that the move to value-based payment in New York includes those CBOs for the fear being that they would get left behind. But there's nothing that would really stop any other state in the country from adopting that specific approach. And I'm hopeful that in New York, it's going to mean a lot of different CBOs are going to get contracts, and we're going to be able to see lots of different models of relationships between health plans, healthcare providers, and community-based organizations in the move to value in healthcare. Next slide. So Rishi, back to you.
Thank you, Jason. Actually, before we go on to the poll question, I think a lot of really great content that you shared there. And in fact, we see a lot of good engagement with folks posing questions to us online right now. So I'm wondering if I could ask you one question while also encouraging everybody else who's listening in to use your questions function to submit questions. We'll be sure to get to as many as possible. And Jason, to that point, there was one question from David Cox, one of the attendees today. And he said, the New York experience sounds good, but very robust to someone in a fee-for-service environment. Can you please define quote unquote value-based? And he says full risk, bonus arrangement, or somewhere in between. So he's wondering if you could just define value-based for those, especially in settings that are predominantly fee-for-service.
Great question. And thinking about value-based payment is it means lots of things to different people. There is no true standard definition. In New York, pay for performance, which is a bonus payment to a provider based on specific performance metrics with no real link to total cost of care, is not actually considered value-based payment in that context. Now, that is not the case in other states. But in New York's case, it defined it as being that the healthcare provider must have some amount, it could be upside only, risk linked to the total cost of care, the services, or the populations that they serve. So that there's definitely a financial risk component, even if it's only an upside portion of that. The reason for that is that our view of the research was that upside, or if you didn't have any risk associated with total cost of care, you would see some potential improvements in outcomes, but if you really wanted value-based payment to be transformative, to get healthcare providers to begin to actually practice care differently, in line and consistent with the objective of trying to get to more cost-effective healthcare, you had to provide some element of risk on the provider side. But that said, different states, different organizations define in different ways. It's a very flexible framework, and you can define it. And when I say, in this case of New York, we have managed care organizations who are the partners of the state in implementing value-based arrangements. But even if you are in a state where it's a fee-for-service state, meaning the state's paying providers directly, there's nothing that would prohibit the state from moving forward with CMS approval of moving those fee-for-service payments into some form of value-based payment structure. So I think there's ample opportunities for this type of migration from fee-for-service to value-based payment to occur in both states that use managed care organizations and those that don't.
Jason, thank you so much. So let me put two of the questions to you, but ask you to hold, just so you can think of them while we hand the baton over to Bill from Nonprofit Finance Fund. And again, there's a great amount of questions now coming in. I really encourage everybody to do what others have done and share them. So Jason, just to keep in mind, there's one question from Lindsay Alexander, which will come back to you after Bill's presentation. Where are there examples of shared savings models that you find particularly successful? And I think I assume that Lindsay is speaking specifically to clinical and community shared savings models. There's also a question from Jenny Sutcliffe about how does a state in New York, I think, plan to track SDH interventions, for example, through the use of Z codes. There's a few other questions that we might come back to, but I just want to, Jason, share those with you while we now turn the baton over to Bill after we ask all of you to really reflect on what Jason shared about the New York State example. We'll again get back to those questions, Jason, that I just posed to you after Bill's presentation. But for everybody on the line right now, we want to understand if what Jason shared, especially the rich kind of experience right now in New York around value-based payments, is something applicable to you. So poll number 3, does your state Medicaid agency require providers to enter into contracts with community-based organizations to address social determinants of health? Go ahead and select your answer now. Another 5 seconds. Excellent. And let's go ahead and close the poll and see what our responses are. All right, interesting. So about 20% of you are in a state that does require this. I imagine that includes, but is not limited to New York. Some of you, 15%, are in a state that encourages but does not require this type of relationship. Almost 30% of you are in a state that does neither require nor encourage this type of work. And the biggest chunk, 41%, are not sure. Well, hopefully today this will encourage us all to kind of follow up and see if there are state Medicaid agency kind of documents, requirements, or even kind of guides that you each have in your state that may lead to the kind of models that Jason was speaking about in New York State. We'll switch now from that really great kind of deep dive on, especially with the New York State example, and now turn to Bill Panakiewicz. Bill, it's all yours, especially to give us a sense of what's happening across the country, and particularly from the perspective of nonprofits and CBOs.
Thanks, Rishi. And I am going to spend the bulk of my time expanding on Jason's commentary on the role of CBOs in the design and financing of sustainable community health investments and partnerships. Next slide, please. First, for those of you who don't know NFF, there are several aspects of our work and how we approach it that inform our thinking on this topic. First of all, we ourselves are a nonprofit. We're a community development, a financial institution with a national footprint, and we work with mission-driven organizations, which includes CBOs, of course, but also public, private, corporate foundations, state and local governments and federal government agencies, and hospitals, hospital systems, and health plans. And 3 main areas listed there for you. Capital deployment, that's the lending to and borrowing by CBOs, and that includes also strategic investment fund design and management for providers of capital. We do strategic financial management consulting focused primarily on sustainable and adaptable CBO business models, capitalization structures to support the risk in those business models, and investment and partnership readiness. And lastly, we do knowledge sharing, field building, and convening on all of those topics. So that lens, how does that lens connect to designing and financing sustainable community health investments? Next slide. So we have a deep understanding and experience with human services CBOs that bring preventative and early intervention services focused on social determinants of health to high need, high cost, low income, and low access individuals, families, and communities. And as Jason pointed out, having deep knowledge of a community, having deep connections to the community is really not enough to bring the sort of skill set and capacities to these partnerships for community health that are needed. And what we wanted to do is emphasize that there are indicators that show the importance and strengths of CBOs as partners in a community health, and we've gathered a few to highlight for you from the 2018 survey of the nonprofit sector that we just completed, 3,400 responses in all 50 states. And the first one of these things, as you can see from the 2 points in the slide below is that their partnering and growth are priorities for CBOs, and these priorities are core to CBOs' investment and partnership readiness. Next slide, please. CBOs are increasingly impact, data, and evidence driven, as you can see from items 2, 3, 4, and 5 in the graph. And CBOs are building the data, infrastructure, and capacities that are essential to sustainable community health investments. Next slide. And they are starting to build momentum in value-based funding, as the data in this slide shows. And our experience in the field is that more and more CBOs are embracing and proactively seeking grants, contracts, and partnership arrangements that are driven by and based on value. And so the importance and strength of CBOs for these partnerships and their success is evident to us in a lot of the work that we do. But some of you, I'm sure, are waiting for what's the but, and the but is coming in the next slide, please. So despite these strengths, there are barriers that are imposed on CBO readiness and partnerships. And I like to focus on the 4 that we see repeatedly in the marketplace. The first is capacity. Increased demand, particularly of high-performing CBOs, can mean capacity insufficiencies for meeting partnering needs, for managing new contracting risks, and for some of the processes and capabilities that end up being essential for managing on an ongoing and sustainable basis in partnerships. Things like the billing requirements that are required, revenue cycle management, musculature that has never needed to have been built in the CBO side, but needs to be built more to be viable partners in these sorts of arrangements. Capital. There's insufficient capital access among CBOs generally, and particularly for infrastructure and balance sheet investments, and for the development and planning for integrated upstream approaches. There's a limited amount of what we call build capital, capital that's required for innovation, transformation, recovery, and growth that are essential components to making this transition to these sorts of partnerships for the purposes of community health. The next piece here are the disparate sectors involved in the community health investments and partnerships. It creates a few things. It leads to uncertainties on assessing readiness. We hear that particularly from the hospital, health systems, and health plan side, saying, how do I know how ready the CBOs are to actually undertake this partnership work? There's also fragmented and siloed funding, which makes it very difficult to coalesce funding into a sustainable business model for the partnership itself. Data access and utilization asymmetry, going back to Rishi's slide of the soccer field, that creates some imbalances in how those relationships work, and cultural divides and expectation mismatches, all of which require a lot of attention. That's already been mentioned to the relationship management side of things. And lastly, policy uncertainty, leading to tension between managing for the needs of today while preparing for the future needs and capacities. And that policy and uncertainty and its impact are basically amplified by the prior 3 barriers that we're seeing. And so we realize that these barriers are not necessarily unique to CBOs, but the message here is that CBOs can and do perform well, but they do so under a system of chronic underinvestment. And so what I'd like to talk about next is, so how do CBOs and their stakeholder partners need to address these barriers? Next slide, please. So addressing these barriers, and I'm going to hit them in order, starting with the CBOs. And the 3 pieces on the CBOs are very important because they speak to one of the points that Jason made about pivoting to shared savings models, the ability to move in those contracts. These 3 items listed here: building the capacity to transition to new business models, strengthening balance sheets and financial management to adapt, innovate, and weather the risks of these new business models, new contracts and new partnerships, and understanding and being confident in full cost of delivering impact, which you've never had to do before at CBOs because nobody cared and nobody paid you full cost. But being able to be sustainable in partnerships really requires a firm knowledge and confidence in them. All of those things are precedent to being able to pivot to shared savings models or other kinds of models based on value-based payments. For health systems and health plans, the understanding the readiness and building relationships and trust with CBOs to convey recognition of their value as a partner is really key. And we recognize, and our experience in the field tells us that there's a need for guidance, tools, and coaching for you to be able to do this. Understanding those financial and cultural disparities and working to smooth them over in transition is also important. And this last piece here, given the underinvestment, seeking collaborative and innovative ways to address underinvestment and partnerships through contracts is something that we see a lot of opportunity for, and that can take various forms: data access, data management, etc. And lastly, in policy and systems, I'm not going to repeat, a lot of this was covered by Jason, but this whole notion of engaging and developing innovative and workable payment and contracting reform, the funding and the contracting is the hardest part of this, and there's very little pre-existing experience among CBOs in how to manage into those sorts of contracts. And that's where the biggest piece of work we see in order to sort of move forward these sorts of partnerships. So I want to move next to the next slide, which is how NFF is seeing ways in which the field is addressing these barriers. So next slide, please. And so I'm going to highlight a few things. These are just literally a handful of the examples of things that we're seeing in the field, frankly, that we're involved in, that we understand best and can be most authoritative on. And I want to kind of tick through some of these things to show how the field, particularly on the CBO side, with support from funders and others, is moving forward the ability to enter into these sustainable community health partnerships and investments. So we partnered with Robert Wood Johnson Foundation, the Center for Healthcare Strategies, and the Alliance for Strong Families and Communities on this partnership for healthy outcomes. That was 200 partnerships across the country responding to a detailed questionnaire from which we derived a report, a number of case studies, and a guide to help state Medicaid officials encourage partnerships. But also in that was, a partnership assessment tool for health, which we call PATH, which is designed for the partnerships themselves to assess their readiness in areas where they need to build capacity to have sustainable partnerships going forward. The Kresge Healthy Outcomes Initiative was expressly focused on CBOs. And that established a learning network, an advisory group focused on 4 large national networks of CBOs, Lutheran Services of America, the Greater Portland Addiction Collaborative, Food as Medicine Coalition, and the Corporation for Supportive Housing. And out of that was developed a CBO readiness assessment tool where the CBOs themselves and those with whom they're working can assess their readiness for entering into partnerships. And the next item on that slide, all of those items on there in terms of building out capacity were a part of the work that was involved in the Healthy Outcomes Initiative, both with the cohorts themselves, the full group, and with individual organizations to build out those capacities that we see as being critical for them to participate in these sorts of partnerships and value-based payment structures and new contract forms. There are a lot of other efforts afoot to build that capacity as well, including the sort of boot camps that Jason mentioned. The other piece of this to address the capital is the directed investment, co-investment, and structured funding vehicles that are already established. Some have been executed, others are in the planning stages to build CBO investment and partnering readiness and infrastructure. We have one called AIM Healthy, which is focused on CBOs in the state of California to make investments in their capacity to enter effectively into partnerships with hospitals and health systems. It provides working capital, real estate funding, and a very attractive interest rates for that, with investors that included the California Endowment, Dignity Health, Kresge, the California Community Foundation, and Blue Cross Blue Shield of California. And so as we see more collaboration on that side of things as one of the innovative ways of addressing that capital barrier that we identified earlier for the CBOs. And lastly, we're seeing CBOs themselves beginning to take much more proactive leadership in advancing some of these innovations in value-based payment reform and contracting reform. And we're in the thick of one of those projects with an organization called Fountain House in New York City, which is in the final stages of designing and looking for support for a demonstration project, which is bundling into a single rate clinical care, behavioral care, social interventions, and care coordination have tied directly the cost of that to savings that they've indicated in their model previously, and looking to create what we think is essential here, which is a contract format which will take us beyond waivers and pilots and give us a basis on which to have scalable and replicable partnerships that can be sustained and expanded over time. And so just to kind of hit a couple of key points that are takeaways for us on this is that we think sustainable community health investment requires a partnership ethos, and that in turn requires focused commitment and contribution on the sustainability of the partnership by each of the partners involved, your partners involved in the partnership, in addition to your own requirements and needs. That partnership ethos needs to be front and center in all this. The other piece that we've learned in a variety of our experience is that partnership moves at the speed of trust. And it's one of those rules that is just inviolable, and that again reinforces this notion on working on the relationship and focusing on flexible service modes that are responsive to the community's needs. We also want to, one of our takeaways is to encourage the use of tools, guides, and calculators, but with support, technical assistance, judgment, and care, and focus on what you are solving for when you use them. Tools, calculators are not the objects of the exercise, and what they produce does not answer the question. They provide guideposts on the pathway to answer the question about how do we build sustainable partnerships that address key issues in an effective way for the individuals, families, and the communities we're trying to serve. And lastly, and I think this is also brought out in Jason's commentary, hospital systems and health plans need support and technical assistance for working with CBOs in these partnerships as much as the CBOs need the support that we've all highlighted as well here. And so with that, I'll pass it back to Rishi, and we'll move on from there.
Thanks so much, Bill. And again, just as Jason was presenting, there have also been a lot of really great questions that popped up as you were presenting, Bill, as well. So let me put a couple questions to both of you guys. One question from John Monahan that came through, and I'll pose this, Bill, first to you, and Jason, if you have any additional thoughts, please weigh in. So the question from John is, could you provide a specific example of the kind of service that a CBO could deliver that can be directly linked to improvement in the social determinant of health for which a provider would pay? For example, in-home meals is one question that John has. So, Bill, I'm wondering if you mentioned Fountain House, and there's plenty of other examples. Would you mind taking a first pass at giving a specific example or two of the type of service that a CBO could deliver that could be aligned with a social need and value?
Sure. And I can use an example that actually is, already has some existing contracts which they're being paid for, and that's medically tailored meals from the food as medicine organizations that are out there. And I think one of the reasons that example works is that medically tailored meals are what I call fairly far downstream on the upstream continuum, which means they're in very close sort of care proximity to clinical care. And therefore, the impacts of things like medically tailored meals for critically and chronically ill homebound individuals are able to demonstrate outcomes and cost savings in a fairly short time frame. And so that's, I think, a perfect example of the kind of interventions that can have some immediate early wins, as you referred to them earlier.
That's great. And Jason, any additional thoughts of specific examples of the kinds of services beyond medically tailored meals that come to mind for you?
Sure, I would point folks to Green and Healthy Homes, which is a national effort. They have really done some interesting things, including in New York, in partnering with both the payer, i.e. the health plan, as well as provider community, doing things like going in and doing remediation in people's homes for triggers for asthma in children and adults. That has proven extremely cost effective in terms of lowering total healthcare costs. I think one of the things that CBOs can do is that whenever you're looking at healthcare costs in aggregate and you're looking at subpopulations and you stratify the populations, you're looking for areas and opportunities where you got bad outcomes and high costs, and you have bad outcomes and high costs where you can actually do something cost effectively to change those outcomes and get to the win-win, better outcomes and lower costs. And I think one of the things that CBOs can do is offer very cost-effective strategies. And one of those I mentioned was that home remediation for the triggers of asthma. I'm also a big believer in medically tailored homes. I would direct people to God's Love We Deliver in New York City, which has a long history of contracting with health plans, providing those medically tailored meals. The last area I would mention that's worth looking at is transitional housing, where you've got individuals who are in long-term hospital stays, who are medically fragile, who can't necessarily transition back to their normal housing environment, but need some sort of transitional housing, or are coming, don't have any housing, are looking for a permanent housing solution. But a transitional housing can be a lot cheaper than a hospital bed or a nursing home, and could give a number of organizations opportunities to find a more permanent housing option. Those are just a couple of tangible examples.
And I would agree with all of those. I would have listed similar ones myself.
Excellent. Well, let me, there's a couple more questions that we're going to pose to you guys before we wrap up here. And I wanted just to first thank both of you for the presentations, a lot of rich content there, and come back to, for all the attendees, including Jason and Bill, this question of now what we've understood as we reflect on your presentations about this core question, how to create a path to sustainability. I want to share a couple of thoughts going back to that image, right, about how to level the playing field. I think we've heard some really great concrete examples of processes and structures, capital, some examples, including the ones that Jason and Bill just mentioned of CBOs that are providing specific types of services that are aligned, perhaps in ways that can level the playing field more quickly for those specific social needs. We also wanted just to share a couple of thoughts that I think reflect a lot of Jason and Bill's comments, as well as the experience that HealthBegins has in this. In terms of how to build and transfer this capability to level that playing field, to move upstream. We're missing a lot of metaphors here, but the goal, I think, overall, from our perspective, and this resonates a lot with what we've heard today, is to really encourage clinical and community partners to plan and structure and even leverage the contracts to optimize and align for the financial risks and rewards, to align payments with disparity targets, something that we've alluded to, I think, in each of the presentations, but we want to call out at HealthBegins. And then also require, see if the contracts themselves can be structured to require the transfer of resources, which could include performance management and technology capabilities from the healthcare sector. That could be not only from the payers and funders, but from the provider systems themselves, to our community partners, including the social sector, public health departments, or other civil society organizations. For example, we know that community-based organizations, as we've heard today, need to identify real costs and calculate the potential risks for providing these types of services, especially when it comes to the current interest in high-need, high-cost patients. We really want to call out the example of the ROI Calculator that the Commonwealth Fund recently put online. This was a ROI Calculator for partnerships to address social determinants of health, specifically for high-need, high-cost populations. We're proud to say that this was developed by a senior fellow of HealthBegins, Professor Victor Tabush. And again, this calculator is available online right now. If you just go to the URL that you can see there, commonwealthfund.org/ROI Calculator. This is one tool that is necessary, but we think insufficient, exactly to what Bill was talking about. A tool is only as good as the technical assistance that supports the implementation of it. But it is a tool that starts to allow us to identify how to calculate those real costs. We also know that, based on the conversation today, that CBOs and partners in the clinical side can align priorities and payments to address the current disparities, as well as overall population health needs that include social determinants. In the previous webinar in this series, we actually introduced the Upstream Strategy Compass as one framework to be able to help different stakeholders in the clinical and the community side to map the existing solutions for defined populations and for defined social needs. So for example, diabetes and food insecurity, which could be addressed through, of course, medically tailored meals on the bottom left of this 3x3, which is a very tertiary prevention, individual focused intervention. But we also know in any given community for that defined population, again, for let's say diabetes and for a social need like food insecurity, that there are a host of other policy interventions that address primary prevention, secondary prevention opportunities, and that the levels of intervention can extend beyond just targeting individuals with those needs, but also engaging organizations and even whole communities to make change. We introduced this in the last webinar, and we introduced that this was a way to start to identify early wins for any given community. For example, illustrative example here of 3 solutions that could be part of the quote unquote early win strategy for a clinical and community partnership to move the needle, not just for high need, high cost patients, but beyond, and how they can articulate their roles, where clinics can lead, partner, and support, and where communities can lead, partner, and support. The last webinar again introduced this tool. We won't go into too much detail, except to use it to reference the fact that the ROI Calculator that we just spoke to is one tool among many that are out there, including the ones that Bill spoke to, tools that are available to help estimate the risks and rewards for these interventions, including the things in the bottom left, and increasingly there are tools, of course, for other interventions at different levels of scale and intervention. For instance, interventions as you move towards the top right of this 3x3. There are many tools that are now emerging that become useful for community partners to be able to optimize their partnerships. And this is the last part that we really believe at HealthBegins, that part of, I think, what we're starting to experience, especially among those vanguard partnerships in the country, including some of the ones that Jason and Bill mentioned, is that there's an opportunity not only to optimize the risks and rewards financially for the current program, but strategically identify ways to reinvest or even reallocate the cost savings from downstream wins to support upstream solutions. Can you take a certain percentage of cost savings from a high need, high cost intervention, for example, medically tailored meals for high need, high cost patients with food insecurity, a bottom left example here. Can you take those cost savings, at least a portion of them, and reinvest or reallocate those to support other upstream interventions that may lack support as a way to build capital? So there's a need, as Bill and Jason were both speaking to have payers and providers provide support and technical assistance to level the playing field. There's a way in which you can map capabilities. There's a lot of readiness assessments out there, including the upstream capability assessment, which we've also shared in the past. The point is really to use the capabilities however you're defining them, whatever tool you're using. From our perspective, it's important to map those capabilities so you can start to identify the strengths and areas of improvement, of course, to make that upstream partnership really successful in a targeted way, so that the TA needs are really directed towards where the gaps in organizational capabilities are. But lastly, that there's a way then to use this capability map to transfer capabilities from one side of the partnership to the other, and particularly in our opinion, from the healthcare sector to the community, using contracts. What Jason alluded to in New York State is a really great example of how the state itself started to put in place guidance documents to help organizations, CBOs specifically, think about how to not just enter these contracts, but also to receive the technical assistance they needed to succeed. And they also, it's a great example really of this kind of bottom line from our perspective, that there are so many different opportunities here, especially with the richness and the wisdom that was shared today from Jason and Bill and their respective organizations, about ways to level the playing field, ways to especially transfer resources. And I'm wondering in the remaining minutes that we have, if I can ask one kind of parting question to each of you guys. The question that I wanted to kind of pose to Jason and Bill come from a compilation of the questions that we've heard online. So for example, I believe Mark Rosen, Lindsay Alexander, and Sally Sundar have shared questions. One question is, as Sally put this most directly, Jason and Bill, what about the chicken and egg phenomenon? When you have an organization that is trying to solidify its infrastructure before pursuing partnerships, and they believe that that's what they need before they invest in these relationships, is that the right approach, or is there a way in which they can pursue partnerships simultaneously so that they're building their infrastructure while they're in the partnership? What's your answer to the chicken and egg dilemma? Do you build infrastructure first before partnerships takes place, or do you do the opposite? Or do you build a plane while you're flying it, I guess? Jason, Bill?
Yes.
Bill,
yes to all three.
Yeah. Expand on that, Bill. Yes to both?
Well, I would just say, in fact, all three ways are being done as we speak by folks. So I think they're, GHHI that Jason mentioned had built a lot of infrastructure beforehand, as have others who have been involved in the pay for success transactions that have been done focusing on health. I think some folks are building building these systems and the infrastructure as they fly them in partnership with folks. And there's a lot of basically self-investment that's being done to get up to speed with it. So I think each organization needs to kind of assess their current situation and see which of those paths makes the most sense for them, given their day-to-day business, the risks they're currently undertaking, what success they're having financially in their business, and what the likelihood is of like-minded partners to work with them on either, building it while they fly it, or do they need to take the time to slowly invest it, and working very closely and I think candidly with their existing funders on how to build that infrastructure too, because I think funders are, the foundations are very acutely interested in building out the capacity of CBOs to be partners in these situations.
Yeah, I agree. I mean, I think you see plenty of examples of people trying to fly the plane and build it simultaneously, in addition to some organizations. Maybe we're fortunate enough to have some investment or seed capital up front. Right. But I think at the end of the day, my suggestion would be a community by community conversation where you bring together the philanthropic organizations that traditionally provide funding for services, for programs to these CBOs, bring those together with the healthcare provider community and the CBOs to have a conversation about this move to value and how the CBO community could be best leveraged to support the goals of the triple aim. And I think that one of the interesting opportunities here would be for philanthropy and to maybe think a little bit differently about how they fund CBOs in their move to value. I mean, traditionally, a lot of the philanthropy looks for their dollars to go directly into service, directly into program, and not go into infrastructure. But maybe in exchange for these organizations and the healthcare providers' willingness to invest and move into value-based arrangements in partnership with CBOs, maybe there's an opportunity for some of the existing monies that are in the system to be leveraged in creative ways to fund some of that infrastructure. I just think those community by community conversations need to happen. And I think that there's money in the system today that could just be used a lot better than it is. And that might be a way to help, because I think a lot of the infrastructure costs here for these CBOs are not going to be that high. And so I think there's some interesting opportunities for some creative partnerships and creative reuse of existing monies within the system.
And what Jason's referring to is that build capital I referred to earlier. Build capital, more general operating support, I think would be very helpful in that regard for folks. So.
Well, thank you both. Grace, let's close us out. I know we're past time. I really appreciate Jason and Bill and all of you. Grace?
Yeah, this has been really interesting and such good questions from all of you. We are going to follow up with you individually if you had a question that was not answered. You can also always reach out to us directly, info@healthbegins.org. You will be receiving an email shortly with a recording of this webinar. And also you will receive a quick survey that'll pop up on your screen as you sign out. We'd really appreciate it if you could take a minute just to fill out those couple questions to let us know what you thought about this webinar, what else we could do to help you in your journey upstream. We'll be taking the month of July off from webinars as our midsummer break, and we'll be back in August with a new webinar for you. Thanks again so much for being here, and we will see you in August.